Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
Inflammaging. It's really interesting because, the skin is sort of the window to the rest of the body in many ways. And as an allergist, immunologist, I take care of both little babies as well as people into their 90s. And so you really see kind of the Benjamin Button phenomenon, sort of from the immature weak immune system all the way to immunosenescence. And there's a lot of similarities between the baby and the 90-year-old in some ways. And all the things that you mentioned are playing out in the skin, from the immunosenescence, inflammaging. That's also playing out in many other organ systems. The same disruption of the epithelial barrier that's occurring on the skin is also occurring on the upper respiratory tract, lower respiratory tract, gastrointestinal tract, etc. So I think that, the skin is far more visible and accessible. And, once we see that, we also see sort of the breakdown in all the other aspects. And that's what kind of ties things together. And that's what makes things really exciting and fun to be able to kind of work with all the other colleagues. So, in our field, in allergy immunology, we're not an organ specific based specialty. We're kind of a transcending inflammatory immunologic theme based specialty. So it's always a pleasure to be able to work with organ specific specialties such as dermatology here. And Larry and I lead our multidisciplinary atopic derm program on the pediatric side. And now we just started this on the adult side with one of the former chief residents in dermatology at UCSD, who's now a junior faculty. So he's Dr. Reed Odenberg. He's doing it also with us on the adult side as well. And then I also lead the same type of initiative with pulmonary for our multidisciplinary severe asthma program too. So it's a really kind of nice way to kind of tie things together. And this all started because, about 6 years ago now, I think, Larry, I kind of cold called him and I said, we see each other at grand rounds and meetings, but we never really worked together. And I said, it's time for us to become friends. And I said, because we have so many patients coming in, it's like, allergy, derm, they come to both specialties basically whenever primary care can get somebody in quickest. And it's like two ships passing by. And a lot of times patients are told, hey, use triamcinolone by one specialty, and no, you got to use, another thing by another specialty, and then use this moisturizer, and then use that moisturizer. And at the end of the day, the patient just throws everything up in the air and says, we're not going to do anything. So it's counterproductive. And I think that as time goes on, we really need to come with a cohesive message and one-stop shop for a lot of these patients. And I always say that, it's not the fact that we're telling everyone to recreate a multidisciplinary center. That's not really possible. It takes a lot of time, takes 2 attendings, and see half as number of people or a third of the number of people, and then also bring on many other care providers. But it's really kind of instill a multidisciplinary frame of mind. And so that's kind of what we're trying to instill, and to be able to go and sort of find your friend and your colleague and be able to think together on this. So, this is the goals and the program structures. We have, talking about sort of the why we have a specialized clinic, and we kind of discuss that. And it's really a collaboration in Rady Children's Hospital, University of California, San Diego, as well, between both divisions of dermatology as well as allergy immunology. And then, of course, Larry and I co-lead this. And, it's really about comprehensive evaluations of multiple specialists to come up with a treatment plan. And we focus a lot on patient education. In fact, sort of the nidus on why we end up forming this revolved around shared decision-making, as well as trying to induce quality improvement. And, we collect so many outcome measures in clinical trials, but we don't really do enough of that in a real-world setting. So we want to be able to bring some of those measures and actually look at how they apply for real-world evidence generation. and be able to really kind of teach patients, because we firmly believe that, a lot of people are not adherent with what they're doing, but they're not adherent because they don't know why they're doing the things they do. So the more they understand the condition, the better they can manage them, and the better they'll listen to what we have to be able to share with them. So, and we want to kind of go through some of the things that we do and the sort of the mechanics and nuts and bolts of this, as well as also some of the outcomes that have come out of this from the data collection. So this is kind of our full team. So we have Dr. Eichenfeld, who is the dermatology director, myself as the allergy immunology director. We also have a clinical pharmacist, who's one of our ICU clinical pharmacists that we kind of support part of her FTE so she can see the light of day outside of the ICU. And then we also have a joint allergy derm PA as well, who really has been dual trained, spent half the time training with me, half the time training with Larry. And she's very unique in that aspect, and she's kind of the clinical coordinator of this. We've actually had two of them that were trained like this, so we're very proud to be able to have that. In addition to that, we also have a lot of research fellows, as well as the pediatric dermatology fellows, and who are participating in rotating through our program as well. And then we also have patient educators, and who also double as quality assurance specialists. They actually collect the data. We have PowerPoint modules that we developed to teach the patients different sets of PowerPoint modules as well. And then we have a variety of different clinical studies, whether they're sponsored clinical trials or our own studies where we're examining sort of things from a quality improvement standpoint, or a real-world evidence generation, or even some of our translational basic science studies where we need samples from patients. So we have coordinators who are readily available coming in and being able to kind of engage with them. And really, if you think about this, is almost utilizing a lot of the models that we've seen in other specialties. Mental health has this type of multidisciplinary program where they've seen a lot of success over the years, and kind of a medical home model, as well as in oncology. I mean, every single oncology patient has some bit of a multidisciplinary approach, and almost all of them are enrolled in some type of study, whether it's actually a treatment study or understanding a mechanism of disease special study. So I think we're really kind of trying to bring things together. And these are some of the patient visit expectations. So we tell them this is not going to be a quick visit, and we're not really going to take referrals from primary care. We really need somebody else to vet them. So they have to come from another dermatologist or another allergist that really have seen these patients, or if they're frequent flyers from the hospital. So some of the images that Larry pulled up, I mean, from our hospital, I mean, if you look like that and you've been in the hospital multiple times, I mean, you can have a direct referral from the hospitalist as well. I mean, recalling, some of the stories about the reluctance of some of these parents in using topical corticosteroids is astounding. I mean, I remember there was a 5 p.m. A couple of years ago, and I was finishing up clinic, and one of my fellows calls me and said, Durham needs you to come and see this patient in the ICU. And it was like, what is going on? And the person was so profoundly hyponatremia, and the sodium in the 1 teens seizing in the ICU, 90% body surface area. And guess what? That person didn't even have any TCS on at all. So again, if you have patients like that, you don't need to go through, another derm or another allergist. You can come directly in. So we do bring in patients through our respective consult services as well. But most of the time, it's going to be someone who's really had a first pass at them. And that's really kind of leading to some of the things that Larry was mentioning, that, the kind of demographics that we're seeing is evolving, because we first started when biologics was a novel concept, and people in the community were a lot more reticent about those. We saw a lot more patients who really just, biologic naive and just coming in, and all they need is a systemic tune-up and being able to select the therapies. Now we're seeing a lot more refractory patients. We're seeing far younger individuals where people in the community may not feel as comfortable trying to manage, and they want kind of a multiple set of eyes on those patients, as well as patients who may have failed or have had intolerable side effects from the first-line systemic therapies they've been on, so they need some additional help. And we don't just get people from our local area. I mean, we even get patients all the way from Arizona, from other parts of California, who actually come in because they heard about our program, and we speak about it at our conferences, where you have different colleagues from around the region come in as well. So we do see a fair number of referrals, and a big part of this is also kind of to set up a one-stop shop for these people as well, so that, if you're going to come in, many of these individuals have lots of different manifestations of T2 conditions. I hesitate to use the word comorbidity, because comorbidity implies that it's just a parallel condition that's happening versus really a T2 inflammatory disease that's just manifesting in a different organ system. So a lot of our patients also have eosinophilic esophagitis. A lot of our patients also have concomitant allergic rhinitis, food allergy, as well as asthma and chronic sinusitis, and we're able to kind of manage these patients collaboratively and together on this. So I think it's really important that these people feel like they're supported and they don't have to go to a whole bunch of places and be able to kind of get coordinated care. And we also try to assess a lot of the things we mentioned that really we only see in clinical trials. Like, it's not just about getting a BSA, although, a lot of times if you just go to general dermatology clinics, even of our own faculty, a BSA is not always recorded. A lot of times it's just mentioned subjectively. Whereas in this program, it's the BSA, it's the VIGA, it's the EASY score, and PPNRS, and DLQI, POEM, and even the National Eczema Association's metrics as well. So sometimes they fill it out online, sometimes we print it out and have the patients fill them out too. So we really want to get a whole full collection of clinician-reported outcomes and patient-reported outcomes as well, because when we engage in shared decision-making, it's not just about shared decision-making, because you can't really partake in the decision-making if you don't know what's going on. So it's really about informed shared decision-making for these individuals. We already talked about, how these patients come to us, and we do have our PA, a joint allergy derm PA, who is kind of the gatekeeper. When someone sends in a referral, she will adjudicate whether it's an appropriate referral and be able to kind of make sure the patients get in on time as well.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.